Hello, good afternoon, everyone. Thank you all so much for joining us. This is the NPRQI Monthly Forum. We're going to get started here in just a few minutes. We would like to invite you to enter your name and affiliation in the chat and let us know that you're here.
This is Timber Snyder. I'm with Deaconess Union County Hospital in Morganville, Kentucky. I'm on the phone. I'm not able to chat.
Okay, no worries. Thank you so much for joining us.
Thank you.
Okay, we are going to go ahead and get started. Just for awareness, we are recording this session for folks that weren't able to make it today. Again, thank you everyone who is able to join us. We are so excited to have you here for the NPRQI Monthly Forum. My name is Lisa Inohasa. I'm the Senior Program Coordinator for NPRQI, and I am joined today with my co-presenter, Crystal Bartley, the Director of Quality Improvement Initiatives with NPRQI. And we are going to be sharing some information today about NPRQI. Before we get started, just a few acknowledgements. The EMSC and NPRQI are supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of an award totaling $2.5 million with 0% financed with non-governmental sources. The contents of today's presentation are those of the author and do not necessarily represent the official views, nor are they an endorsement by HRSA, HHS, or the U.S. government. NPRQI is also supported by the Toyota Way Forward Fund. NPRQI is housed at the Dell Medical School at the University of Texas at Austin. The University of Texas IRB has reviewed this initiative in full and determined the project to be exempt from human subject research. At this time, I wanted to hand it over to Crystal Bartley, Director of Quality Improvement Initiatives, to share the importance of pediatric readiness.
Hi there, everyone. Thanks for joining us today. So what we're going to do is start today's session with giving you a little bit of background information. Then we'll go into sort of more in-depth information about what we're measuring with the NPRQI platform. And so the next series of slides, what we'll do is walk through the pediatric readiness component. And we're giving you a brief update of pediatric readiness, but it's a much more larger initiative that has been going on for several years. But the very impetus for it is that we want to ensure that every ED is capable of maintaining and stabilizing a child, regardless of the ED's volume or their geographic location. And so with that being said, we try our best to ensure that EDs that see fewer than 15 kids a month or a week have the proper equipment, resources, personnel, available to sort of be able to take care of that child. And so pediatric readiness really means the people, the processes, and resources that are in place to provide the highest quality of care for children. Next slide. So we always start with this concept of you can't prove what you don't understand. And when you think about it, we typically have a hunch like, oh, you know what, we're not providing the fastest care we can for a particular intervention, or we know that some of our peers are doing better than us on specific measures. But the one thing about quality improvement is that it gives your site a systematic approach to investigating a change that you're interested in making, using data to drive those improvements, and then subsequently deciding whether you're going to adopt that intervention, adapt it, or abandon it altogether. One of the things that we do within the quality improvement realm is that we typically focus on evidence-based content, or we will go with group consensus-based feedback from our peers. We know that 85% of children are seen in EDs that don't specialize in pediatric care. and that there's a 76% potential mortality risk reduction when there are EDs that are exhibiting high pediatric readiness. And so what we'll do now is go through a series of slides to sort of describe how your site can sort of reach that pathway to become more pediatric ready. So there is the National Pediatric Readiness Project that empowers EDs to improve their ability to provide high quality care. It's a free assessment that's available that provides a gap assessment. So you sort of understand how do you sort of stack up against the national standard. And then it also provides resources available. And you guys will see a new version or iteration of that assessment being released in 2026. Our team provides a framework to help you address those gaps, implement those solutions, and track improvements. And what we hope is that over time, you integrate quality improvement initiatives that are pediatric focused into your standard practice. So think about it. You have these CMS measures, you have tons of sort of initiatives that are adult based, but then I'll ask you or sort of put you on the spot and say, what are you doing for pediatrics? And so our goal is to fill that gap. And so what you'll see in the next series of slides is a strategy to help your sites address some of the needs related to quality improvement and within the pediatric realm. Next slide. Here you see a pathway, and I know you're gonna have to sort of zoom in a little bit for it, but we've outlined the route to get all emergency departments sort of ready to take care of any kid that comes in. And so we describe it in 6 phases that you'll see here, where you take the assessment, you work with your leadership to get the buy-in. There's a checklist to, if you're not ready to take the assessment, but you want to see what components are there, that's readily available for you. You complete the assessment, the website is always available to you. The next phase is reviewing it. So you get a score, and that score will help you sort of understand how you compare to your peers. Then you work on the improvement phase, and we share resources that are available to you. Some of your states are actually endorsing a program where you can become or can be endorsed as a pediatric ready site. And so we have more information with that on our website about you can find out how your state will give you that designation. And then later it's about maintaining and showing stability over time with your improvement efforts. Next slide.
And I'll take it from here, Crystal. Thank you. So I wanted to share a little bit about NPRQI's role in the pediatric readiness. The National Pediatric Readiness Quality Initiative, for those of you all that are new or learning this about this quality initiative, it is a free, self-paced quality improvement data platform specifically designed for emergency departments. What it does is it helps EDs to measure, to benchmark, and improve their performance on key pediatric processes in a secure way. One of the biggest benefits is that it gives hospitals a clear framework for continuous quality improvement, which is really essential for improving pediatric readiness and making sure that kids get the best possible care. And here is why this tool is so important. It really helps EDs to track their progress while implementing their quality improvement projects. Without NPRQI, it is really hard to know if the changes that your site is making are really making a difference in moving the needle of pediatric readiness. Ultimately, NPRQI is designed to inform and empower frontline staff so that they have the insights and the tools to really make those needed improvements. This is a visual representation of NPRQI implementation for a path to better care for pediatric emergency care. And what you see here are the different stages of implementation, which begin with access to a free, secure web-based platform, the ability to capture pediatric patient encounter, being able to have real-time measures and performance dashboards that can help you identify specific areas to focus on so that you can actually transform your performance data and then use that information to really kind of reflect and align your site with high pediatric readiness, and also align your site with your organization's strategies. With NPRQI, EDs can select from these 7 clinical conditions that you see here on your screen. These conditions also come with 28 nationally vetted evidence-based clinical quality measures that EDs can actually use to benchmark their performance. And here is where NPRQI is really unique, is that it's actually closing the gap on a missing piece of information, which is really a way to truly understand what's happening with individual patient encounters in the ED and understanding the quality of care that's actually being delivered across the entire US. This is something that sites have never seen before. And I'm going to give it back to Crystal to go into a little bit deeper dive into NPRQI's clinical conditions and measures.
Thanks, Lisa. So when we go to this next slide, what I want you to sort of keep in mind are these 3 tenets of NPRQI. Our goal is to provide you with resources to measure your performance, the ability to reflect on what you're observing, and then the ability to improve on your performance. And so with those 3 tenets in mind, when we say measure, we're thinking about metrics. So yes, I'm going to give you some background information on quality improvement, but then also sort of the actionable piece of that. And so think about it. When we talk about quality improvement, we typically discuss 3 types of measures. So you have a structural measure, which gives you an idea of the infrastructure in which care is being provided. It doesn't tell us about anything about necessarily the quality, the process, but do we have characteristics of where care is being provided or the care team itself? Process measures gives us an idea about care delivery, the appropriateness of care, inappropriateness of care, timeliness, efforts sort of along those lines. And then outcome is what's more important to our sites and our families, right? It's the end result of the care that we're providing. The reflection piece is what you hear us talk about with dashboards. So it's great if we are measuring it, but you need to be able to sort of visualize that content. And so NPRQI, as Lisa mentioned, will give you the ability to identify those trends. You'll be able to compare your performance against your peers, and not just any peers, but it's those peers that share the same ED volumes as yourself. But you'll also get a snapshot of what national performance looks like. And then lastly, improve. So remember I said earlier, you're going to have the option to abandon, adapt, adopt. Good job.
Mm-hmm.
I was like, I'm missing the 3rd A. And so that's where you're really doing your improvement efforts, right? And your model for improvement. And we'll spend time with you all working through this. And we have a couple of initiatives coming up to really give you that sort of concerted, guided, hands-on emphasis to help you through this process. So on the next slide, what we'll do is start showing you sort of the structure of our measures. And so NPRQI looks at all pediatric patients. So we aren't going to say only show me a subset of who's available. We start with an undifferentiated diagnosis for kids. So you can look at purely just the assessment phase of the ED experience, but we also continue through the entire sort of experience of the patient. So we look at assessment, diagnostics, intervention, and disposition. And so the measures that are associated with each of our bundles has elements that are listed on the right-hand side. So you're going to see some related to diagnostics, some related to disposition. And we have those core bundles that Lisa mentioned. Next slide. So remember here, and I want you, and I'll walk you through each of these bundles and sort of give you what the importance of these measures are. But our 7 clinical areas of focus are assessment. So we look at abnormal vital signs and reassessment, interfacility transfers, blunt head trauma, seizures, respiratory complaints, vomiting, and suicidality. Next slide. And so when we start this sort of process, we think about the recognition and assessment of a sick or injured child. That first measure that you see there is the percentage of pediatric patients that are their weight is documented in kilograms. And the importance of that measure is that we want to weigh patients in kilograms because this is an opportunity for us to prevent medication errors, specifically medication dosing errors. The percentage of pediatric patients with pain assessed is more of a patient-centered measure. And our goal is to ensure that we are recognizing when our pediatric patients, especially those that are younger age, have complaints of pain, and that we are recognizing it. When you look at the next series of measures, it's related to vital sign reassessment. So we know that vital sign assessment serves as an early warning of the changes in the patient's condition. And so that can assist us in preventing the deterioration of that patient. When you look at the median time from the collection of our first set of vital signs to first intervention, that one's totally related to the timeliness. And when you think about your IUM domains, it falls under that bracket. And we know that early recognition of an abnormal vital sign allows us to provide timely interventions. And then lastly, you have a measure related to disposition, so ED length of stay. And that accompanies a couple of the IUM domains, so timeliness, effectiveness, and patient-centered. And it gives us an idea of sort of our time to definitive care for the patient, but it's also a global marker in aggregate for how efficient our care processes are within the emergency department. And next slide, Lisa. And so now when we look at the IFT bundle or the interfacility transfer, this is really about our ability to provide effective transfers for our pediatric patients according to the resources that we have available. Here we have 3 measures, one of them related to the percentage of transferred pediatric patients who met your site-specific criteria for transfers. And that just gives us an idea of effectiveness, right? So we look at all available resources that are being provided to that patient. The other measure is the timeliness, so time from arrival to transport, and that gives us an idea of the timely recognition of the patient's clinical needs to their departure. And then lastly, you think about the percentage of those patients that were discharged from the receiving center less than 24 hours of their arrival. This is our efficiency measure. And the goal is really to minimize costs. It gives us an idea of the institutional and family burden associated with transitioning a family to another facility. And now, Lisa, let's go to blunt head trauma. So for blunt head trauma, we're looking at sort of 3 phases of care. We're looking at the assessment phase, diagnostics, and intervention. And when you think about the assessment phase, we look at the percentage of patients with a full set of vital signs obtained, and then those percentage of patients with the Glasgow Coma Scale that's been reassessed. And those 2 elements are really about the early identification of blunt head trauma, and then the early recognition of clinical deterioration following the blunt head trauma. Then when we switch to the diagnostic portion of their ED encounter, we look to see the percentage of patients with a head CT that met 1 or more of the PCARN criteria. Our median CT radiation dose was what we previously had listed. But this is all about safety, right? Our goal is to minimize radiation exposure in the assessment of children that are coming into our EDs with head trauma. And then lastly, the intervention component is those percentage of patients that received hypotonic saline. And we call this one a measure that's related to the safety and effectiveness of the care we're providing with the goal of decreasing harm in the management of children with head trauma. And so now we're going to switch to seizures. So you're going to notice that we give you sort of a plethora of options. And our goal was to find some chief common complaints that emergency departments see with pediatric patients. So we pulled some common complaints from emergency departments. We got feedback from some subject matter experts on particularly what was the evidence associated with these chief complaints. And so those measures that you see here listed have gone through what we call a modified Delphi process to help us identify which measures are going to be the most meaningful for teams to drive quality improvement efforts. So when you look at seizures, we focused on assessment, intervention, and diagnostics for that bundle. It's the percentage of pediatric patients with a neurologic reassessment, the percentage of those patients that received at least one additional class of antiepileptics, and the percentage of patients who underwent some diagnostic testing. And really the focus of those are related to early recognition of deterioration in this patient population. We wanted to ensure that patients with prolonged seizures receive the appropriate medication. So that's the one that's related to receiving at least one additional class of antiepileptics. And then lastly, we wanted to decrease unnecessary patient testing in the management of seizures. And so that's why we have that diagnostic piece to assess which labs were being drawn and which assessments were being drawn on patients. Now we're going to switch to our focus on respiratory complaints. And this is all about adherence to some evidence-based guidelines that currently exist for respiratory conditions. And here you'll see these measures are really related to the effectiveness and timeliness of care. And they are primarily related to interventions and diagnostics. So our goal is to decrease the severity of respiratory distress in asthma and croup. And so you'll notice we have measures related to looking at the duration of distress in those patients. We look at the severity of the distress. So that measure, that's like the percentage of pediatric patients over 2 with a diagnosis of asthma that received a beta agonist. We look at the duration. Our goal, at least with the latter portion, is to decrease the inappropriate use of antibiotics in these patients with respiratory symptoms. And also with the last one, those with chest x-rays. So of course we want to reduce their exposure to radiation for those patients with respiratory symptoms. And so now Lisa, let's switch to vomiting. So yes, this one is not a very special one. You rarely see measures related to vomiting, but we do offer that to the team. And so remember, you're going to submit every patient that comes into your ED. Well, you have the ability to submit every patient that comes to your ED, but now imagine it's holiday season, it's Thanksgiving, and you have a child that comes in with a complaint related to vomiting because they've had some great Thanksgiving food. Now you'll have some measures related to that in specific, in particular. And so when you look at these measures, it's all about intervention. So we look at the effectiveness and the timeliness of the interventions that you're providing. And so our goal is to increase the number of patients that are receiving treatment for vomiting, decrease their duration of nausea and vomiting, but also increase the number of patients that receive non-invasive rehydration measures. And so this bundle is pretty simple, but we know that it's meaningful for families, and it's one of those that we would consider a quick win for teams over time. And then lastly, what I want to discuss is acute suicidality encounters. And so this one specifically focuses on assessment and intervention. Due to the significant increase in the prevalence of EDs that are seeing kids come in with mental health concerns, it's important that we focus on providing standardized suicide screenings. And so the measures that you see here listed are related to us providing some structured assessments, and then also that follow-up that should occur. So we see that we are trying to determine whether you provided an evaluation by a licensed mental health professional just to reassure, provide treatment, and then optimize patient safety. And then lastly, it's important that a safety plan, which is definitely essential, is provided to patients, because we know that fewer than half of patients that seek emergency care for psychiatric services receive that follow-up. And so we would like to track that and provide that for you on a dashboard. So Lisa, can you go to the next slide for me? And I'm going to hand it off to you.
Yeah, thank you. Thanks, Crystal. I know that was a lot of information. Just wanted to pause for a brief moment to see what questions folks may have about any of the information that we've covered up until this point. Anything about NPRQI, about the measures, about data entry. Folks are welcome to unmute to ask their questions. They can put their question in the chat. We are happy to answer any of those questions. Yes, hello, I see a hand up. Go
Yes,
ahead.
hi. I'm Alexander Yacht. I'm in Rochester, New York, and at the Children's Hospital. But we are very interested in looking at across the state, actually, with community hospitals, the management of pain experience during IV insertion and phlebotomy, which is probably the most common painful procedure for children everywhere. And I'm just wondering how that would fit in your assessment piece, or is there an option for adding something like that to your current 6 areas?
Yeah. Crystal, did you want to take that?
Sure. So you are looking at a very specific intervention, and then looking for an outcome. Currently, our platform does not allow you to sort of pull out a targeted intervention and then see sort of the outcome related to that. But what I would say, and I say that as in your area of focus is specifically, you mentioned IV insertion. Is that correct?
Yeah, it's really the management of IV insertion and phlebotomy, because pain is associated with that. And I was kind of figuring out, because pain is part of the assessment section, how would that fit in there?
So we capture it globally. So we will ask you whether or not you assessed pain and you did a reassessment of pain, but we don't actually pull your pain numbers. So we don't ask for the actual values. We ask for first intervention, and we're almost certain that that's probably not going to be your first intervention when you are in the emergency department. So you'll have to extrapolate some of that information yourself to find out the timing of those insertions. And if that is when your first pain assessment occurs, then you'll be able to pull that data, but it's going to be contingent on your workflow. But what I would say is we should probably meet with you. There is an ability to download your raw data set from what you enter into the system, and maybe we can help you sort of isolate the particular metric that you're looking for.
Yeah, we're trying to see basically, we think, and we see in other studies, that the use of topical anesthetics, particularly lidocaine, LMX, JTIP kind of thing, is very grossly underused. And so it sort of is a cross between that pain thing under assessment, and then under vomiting, you have management of vomiting. So it's really sort of the management of pain was sort of a cross between those two. And if it's not there, or just a suggestion, maybe that's something that could be done. So we are looking at it at the statewide EMSC initiative. So this is one thing to look at.
I think you bring up an excellent point. So what I'll do is I'm going to connect you with Casey. She is actually our steward for our quality improvement collaboratives. And there is a pain bundle that is available. And so I know that that team has some interventions in place, but they may be able to sort of connect you with some other groups that may not be looking at pain in the same way that you are, but it might be an opportunity to collaborate and see what strategies they have in place, and maybe an opportunity to benchmark or develop a community of practice. So what we're going to do is connect you with Casey, and I see you'll see her last name is Petika, Petika. So if you shoot her your email, we'll get you connected. I see there's a question that came in from Adam. So Adam, currently, the burden is on the site to submit data at this time manually. We are currently working on strategies to do an EMR data extraction, but that's something that's currently in the works. But Lisa will be able to provide you some insight on what that sort of burden looks like up front, to really see what your what would be the sort of effort that your ED would to produce to do.
Thanks, Crystal. And just to provide some context for folks that are just now learning about NPRQI. So NPRQI was specifically developed for low-resourced, low pediatric patient volume, often rural sites. So these are sites that probably have never done any type of quality improvement work, or if what they've done has been very sporadic. So really, this program initially has been intended for those specific sites. That's why we're really kind of taking a very holistic approach instead of kind of being able to really finitely describe specific things. We're looking at it in a kind of the 50,000-foot view so that EDs can really get a sense of what the quality of care is for each of the pediatric patient encounters that's entered. And obviously, the physician that spoke earlier from the Children's Hospital in New York, I know that you guys are probably no stranger to quality improvement and have probably do this, in your sleep. And so I understand that y'all are probably looking for a little bit more advanced information, and we can definitely work with you offline to help identify how you could pull some of that information. But just understand that at its face value, this is designed initially for entry-level quality improvement for sites that have never had any type of quality improvement experience or very minimal experience, and especially for sites that are low resource, low pediatric patient volume. To speak to the data entry piece of it, at minimum, we ask sites to do at least 10 charts on a regular basis. Initially, when you're collecting your baseline data, we recommend entering around 30 charts just to get a sense of what your baseline performance is, and you can view that on your performance dashboard. And then moving forward, we recommend sites entering at minimum 10 records because on our graphical interface of our charts, a minimum of 10 records are needed to actually show one data point. So that will help you to be able to kind of connect the dots, so to speak. It is manual data entry. And again, that was specifically designed because we were targeting low-resourced, low pediatric patient volume sites. Many of our low pediatric patient volume sites, which are over half of the sites that are participating in NPRQI, many of those sites will enter all of their pediatric patients. Sites that have higher pediatric patient volume, we recommend taking a systematic approach to data sampling. So maybe looking at every 10th chart, every 20th chart. If you're a really high pediatric patient volume site, like a children's hospital, maybe looking at every 30th chart. So it's really just about extrapolating some of the charts and not doing all the charts. But again, some of our low pediatric patient volume sites will actually enter in all of their charts. And it is manual data entry. I would say that initially when folks get started, they report that it can take 15 minutes or a little bit longer to do one specific record entry. As folks get used to the flow of the data in the data platform, that really is reduced down to about 5 minutes or less, depending on the pediatric patient encounter. You can enter up to 10 medications in the data portal. So if you have a patient that has multiple medications, of course, those would take a little bit longer. And then as Crystal had mentioned, we have had multiple pediatric patient volume sites. I want to say we have well over 15 high pediatric patient volume sites. And I want to say about 8 of those are children's hospitals. that are participating. And what we have heard from some of those sites is that we're entering many charts. Yes, this can be kind of a heavy lift. And so we have heard that feedback. We are looking into the possibility of having data electronic pulls from electronic medical records. We do not have that at this point in our development, but that is something that is definitely on our radar because that has been a concern from some of our sites. What are the questions? Norma, hi.
Hi, thanks. I'm wondering if any of the sites have told you that they have created electronic polls through their local ITs, if it's something that your sites commonly do. And then I have another question.
Yeah. I think they may do that with maybe their trauma registry, their stroke, their STEMI. I have not heard that other than to say if sites have an IT department that they work with, they can message the IT folks and that person can actually pull the data systematically and then they can use those records.
Thank you. And then I put
Sure.
my first question in the chat that when I was
Okay.
looking at the measures pretty closely, I wasn't sure to begin with whether like the higher percentage of antiemetics, if that goal was to be higher or lower. And then as well as like the CT and the PCARN score. Is it pretty clear when we enter the database, will it say higher is better for each measure? Or are typically most of the measures higher is better?
Yeah. At this point in time, there is no indicator in the data portal or the performance dashboard in terms of, kind of what direction you want to go. That's another thing that we're working on in terms of being able to annotate that information. But Crystal, I don't know if you want to speak to her additional
Sure.
question about the measures.
So what we can do is give you a cheat sheet. So how about we provide you with this? We have been talking about resources as we are making an upgrade in 2026 of our platform to this new and shinier version of the platform. But we can provide a resource that shows you the measure, gives you that sort of important statement that I walked through for all of them, but then also shows you the appropriate direction of what improvement looks like. And so that'll help you as you're sharing your charts, or I'm sorry, your graphs and your data with your leadership to give them idea of what they're looking at. So it'll help with your messaging. So we can definitely provide that for you.
Nice. What other questions? Do we have any other questions? Casey in the chat. We did have a little bit more information to share. Just wanted to make sure that we captured the questions up to this point. Nothing else? Okay, we will continue. So what we really like about NPRQI is that it is easy to use as a quality improvement tool that can really help your ED improve your site's pediatric readiness. Pediatric quality improvement, as many of you all know, is the leading driver of pediatric readiness, which is associated with improved clinical care and health outcomes for children. We mentioned earlier, 85% of children are seen in EDs that don't even specialize in pediatric care all across the US, but also recognizing that there's a 76% potential mortality risk reduction for those sites where kids are treated in EDs will have where they have high pediatric readiness. I think really the big take-home message for NPRQI is that you can't improve on something that you really truly don't understand. And quality improvement is really all about using data to inform meaningful, actionable change. NPRQI really simplifies quality improvement by offering the set of metrics, customizable dashboards, and support resources that enable EDs of all sizes, of all pediatric patient volume sizes, to participate even without any prior quality improvement experience. NPRQI really helps EDs to identify gaps in quality so that they can be certain that the care that they're providing is really making a difference for their pediatric patients. An additional benefit to participating in NPRQI is our availability of office hours. I think this is kind of a unique thing that we offer. I've spoken with clinicians across the US who do data entry for trauma, stroke, STEMI, and they're like, we never get any one-on-one office hours time. So this is a great opportunity for sites, whether you're new at quality improvement, whether you've done this before. We provide twice a month, one-on-one coaching and assistance with either, getting started, optimizing your chart sampling strategies, helping you to identify ways that you can actually streamline your data entry, helping you to unlock insights from your performance dashboard for those sites that need help identifying a specific area of focus. We can meet with you on that. And then also offering very tailored quality improvement coaching as well as intervention strategies. So we have a plethora of tools available for intervention strategies. So this is not something that you have to go back to your site and figure out a way how to do this. We provide those tools for you. And so you can take that back to your team, discuss amongst yourselves what would be kind of the best thing to look at. Do you want to start off with education? Do you want to do an intervention around policy? Do you want to do an intervention around optimizing your electronic medical record? So there's a whole host of things, resources available that really kind of guide you step by step on how to actually implement quality improvement geared for high pediatric readiness. I did want to take another opportunity to emphasize the importance of data can make and the measurable impact that it can have on the quality of care. Again, NPRQI really helps your EDs to transform your pediatric data into meaningful pediatric quality improvement. And just again, the measures for NPRQI are really all about measuring, reflecting, and improving. And through this collaborative model, it really empowers teams to deliver better outcomes for every child. We do have, I was speaking of resources earlier, we've got, I think Casey has already put or will be putting our website in the chat. We have a variety of resources available. So you may be listening to this for the first time and say, I am in, but I'm going to have to do a lot of convincing to my leadership. So we've got some ED leadership and C-suite promo package where really you can just kind of copy and paste targeted talking points and send it off in an email. We've got obviously our NPRQI website. We've got some flyers around a quick start guide, an infographic. And then we also, I think Crystal had mentioned this, we are also going to be launching a EMSC NPRQI collaborative beginning in January. And so this is a great opportunity for sites that have never really done a deep dive into quality improvement. Think of it as a master class for quality improvement where you have nationally known subject matter experts from the field of pediatric emergency medicine being able to provide feedback on quality improvement work that you're actually implementing in your site. We're actually going to be tapping into their knowledge and experience to speak about specific subject matter areas for the collaborative. And I think Casey's probably going to be able to post a link in the chat where you can get more information about this collaborative. But this is a great way for sites to really kind of go step by step, not just by themselves, but with a group of people just like themselves who are doing this type of work, some who have more experience than others, but it's also a great way for peers to connect, to be able to provide technical assistance to each other. Oftentimes we hear sites saying, oh, I had that same problem. This is how I addressed it. Maybe I'll send you my tool. This might be helpful to you too as well. So we've got some great resources available for sites as well. So again, just wanted to pause and see if folks have any additional questions. Again, you can put those in the chat, you can unmute. And then our last slide, just lastly, our QR code that can link you to the NPRQI registration. We would love for you to join NPRQI to get better data and help your site make better decisions so that ultimately you can provide better pediatric emergency care. What questions do you all have? The questions that we already covered were great. If you do not think of a specific question at the moment, you're welcome to email myself or Casey about those specific questions. I think she's also put the participant organization agreement. This is the agreement that needs to be submitted. We encourage sites to submit this as soon as possible. Some sites can get it done in a week, 2 weeks. Other sites take a little bit longer. We are upgrading our system in January 2026. Up until this point, it has been hosted by an external vendor. We are bringing the entire platform and the dashboards in-house to Dell Medical School at the University of Texas. And so we're so excited about that. We're excited about some of the upgrades that we're going to be able to offer our users. But the important thing to know is that the participant organization agreement for 2026, which should be in the chat, that will be required for participation, as well as for folks that want to participate in the upcoming collaborative. That POA will be required as well. So if you have any questions about that, please feel free to reach out. We hope that this session was very informative for you all. And again, if you all have any questions, you're welcome to place those in the chat. We'll hang out for just a few minutes. If sites have any individual or specific questions, or again, you're welcome to email those.
Annalise, it looks like you do have 2 questions in the chat.
Okay.
First, will these slides be made available after today's presentation?
Yes, we will send out the slides, and we will also make the recording available as well.
Right, and then
Great
might
question.
be either you or Crystal can help answer this question. But when asking about complaints such as vomiting, is this referring to an event prior to arrival, or only if it's been witnessed by the emergency department staff?
Crystal, you want to take that one?
This would be prior to arrival. So imagine a kiddo that a parent arrives and they say, my child has been vomiting for the last X days or hours, and versus it being an experience that they have during their ED encounter. Does that help, Monica? Okay.
What other questions do folks have? Well, we hope to see folks. We've got another NPRQI Forum session in December that's going to be covering data sampling around NPRQI. I know Casey is going to be hosting a conversation, I believe, on the 18th of November about the upcoming collaborative. So if that sounds like something of interest to you or to your site, that would be a great opportunity to hear a little bit more about that specific collaborative. Again, thank you all so much for taking time out of your busy schedules to join us today for the forum. And again, please let us know if you have any additional questions. We would be happy to discuss further, either via email or over the phone.